Sorry, I just came out from COVID. I have a negative test, but just to be sure, I leave the mask on, okay? I am Miklós Keszég. I work at Uzsoki Street Hospital Department of Orthopedics and Traumatology, and let me present you my 9-month progress report regarding my PhD. I am investigating the long-term results and complications of cartilage replacement in the hip, knee, and ankle joint. My vision is to give a clinically relevant overall picture about the consequences of the cartilage replacement surgeries, and for that I would like to use functional MRI and then X-ray scores to evaluate the outcomes of the procedure. In this topic I have three topics. The first two is already done and published, and the third one is still ongoing. I would like to speak about the first two. In this retrospective cohort study, we investigated the long-term outcomes of knee and ankle mosaicplasty procedures in a specific population, football players who had small to medium-sized osteochondral defects. As I said, we made two different articles in it, and we already published, and it's available at the Journal of Cartilage and Joint Preservation. This is a high prestigious journal of ICRS, and both papers are there. About the background. So basically, football has an inherent risk for joint injury, and the knee and ankle injury is quite common in it, and therefore osteochondral lesions can occur in higher risk as normal population. Regarding knee, it can be there in 36% of the patients who is asymptomatic, and with symptomatic patients, it's almost 100%, and it is still challenging what to choose for athletic population regarding to go back to their athletic life. And additional information for ankle, there is no enough clinical data to make a proper guideline, and therefore our clinical findings are quite important in this topic. Our clinical question was that what is the long-term outcomes of knee and ankle mosaicplasty in football players, and we investigated football players who had operation more than 10 years ago in our department with mosaicplasty, and we measured the outcomes of the procedure with functional scores, MRI scores, and return to sport time. Some results. What is quite important in both studies is the high follow-up time, which in knee it's around 80 years, so exactly 17.5 years. And I would like to underline that almost 30% of our patients had operation more than 20 years ago, and despite this fact, the functional score, so IKDC and MOCAR, the MRI score is around 70 and 80%. Which is quite good outcome regarding mosaicplasty. As a matter of return to sport, 80% of our patients could return to sport, and almost everybody is to the same level as before the surgery, and it took only half a year for the patient to go back to their sport activity. Regarding ankle, the same, we can say the same here with the follow-up time. It's uniquely high as well, with 13, almost 14 years of follow-up, and the functional scores are quite promising. I would like to highlight that the MRI score is around 50%. But we only had 13 football players who had available MRI scores. Therefore, it's just directional, so we couldn't conclude anything from it. But regarding football players and ankle, there is no other studies which use MOCARD. So in the future, it can be a promising details as well. With ankle mosaicplasty, the return to sport time was a little bit higher, so it's around 1 year, because in this case, not just the ankle were operated, but the ipsilateral knee as well. So the donor site is from the knee. So there is 2 operated joints in the player. So therefore, the rehabilitation time is a little bit higher in this case. So, summary: our strengths of these two studies: the long follow-up time, the investigation of specific population, and using objective MR and functional score to evaluate the outcomes. Limitation comes from the retrospective study design, because we didn't have a baseline score as originally from 20 years ago, and patients has only one. So the last MRI follow-up, there was no MRI imaging in the meantime. But we can implicate for surgeon that we can have a feedback for them, and we can reconsider the indications of the mosaicplasty procedures, and we could provide clinical data for future studies and guidelines, and of course we see the necessities for what is important to build up a prospective follow-up in the future. So in conclusion, basically we can say that both for ankle and for knee, mosaicplasty is a reliable option in athletic population treating small to medium size osteochondral lesion, and with a good long-term outcome, even with similarity to other studies findings, even if them only short or mid-term follow-ups. Regarding my third study, this is an ongoing systematic review and meta-analysis, and in this one I'm investigating the difference between mosaicplasty and microfracture for treatment to small to medium sized osteochondral defects in the knee. And the background is basically the same as it was before. So just a picture about how it looks like in an arthroscopic finding. This is an osteochondral lesion for thickness, and it can cause the symptoms and therefore the impaired quality of life. And there is basically for microfracture and mosaicplasty, the indication are the same, and therefore our question was that which arthroscopy method to choose in small to medium sized osteochondral lesion. And of course, for that we investigating patients with osteochondral defects with the comparison of mosaicplasty and microfracture, with the outcomes of knee functional score, MRI scores, and other rate of failure, return to sport time. And we would like to recommend the surgical approach, which has better clinical outcome. With the third project, the data extraction and the risk of bias analysis is done, and I would like to submit an manuscript in this year September, so for the systematic review and meta-analysis. Thank you for your attention.
Thank you for your presentation. I wanted to ask you concerning your third project, that for now, how do you decide whether it's a microfracture or mosaicplasty what you apply for these osteochondral lesions?
Actually, it's not that easy to decide what to do. So basically, it depends on the department as well. If the surgeons are ready to use mosaicplasty, and all the equipment are available. And basically, it's a little bit difficult, procedure regarding microfracture, and in this case, arthroscopic finding can be a decision-making option. What kind of full thickness osteochondral lesion, the exact size, maybe, and the location as well, and of course other factors for the patients, for the age, the physical activity, and so on. If we would like to achieve almost physiological cartilage surface, we should try a mosaic plastic because it can provide that. So basically, there is not just one exact decision making. So it's a path.
Just to add to this question, you have to be aware of that microfracture results in a fibrocartilage at the site of the defect, and the biomechanical properties of the fibrocartilage are lower than the hyaline cartilage. When you choose which method to apply, you have to be aware of this fact as well.
Thank you.
Yeah, I have two technical questions actually. The first one is that in your published papers, did you actually affiliate translational medicine?
Yes.
So does it show up?
Yeah.
Very good. Okay. The other thing is that, so, I mean, you say that optimism and pessimism, and the difference is the lack of information. So which one is which? I mean,
yes.
I mean, personally for you, when you get the information, you get optimist or pessimist?
I get optimist.
Very good.
If I have the right information.
Okay. Maybe because maybe that's not the case in everybody. I mean,
maybe.
But for this generation who's sitting in this room, I mean, that would be good to have this approach.